All right, welcome everyone. Welcome to those of you in the auditorium with us. I had a question already on Zoom. Where is this place? We are in Penn Hall Auditorium. If there's anybody on Zoom that is trying to make their way here, we are in Penn Hall Auditorium. Welcome to those of you who are here with us live. Welcome to those of you who are with us on Zoom. I know there's still some people coming in. My name is Justin Mutter. I'm the director of the UVA Medical Center Hour, which is a program of UVA's Center for Health, Humanities, and Ethics. We just have a fantastic program for you today that a lot of people have put a tremendous amount of time into. Want to thank everybody. I won't name everyone at the risk of leaving someone out. I know Angie has a few thank yous as well, but just want to offer that thanks because this has really been a great team effort. Really quickly, before I jump into just a couple of slides about continuing education credit, there will be a question and answer session. Those of you who are on Zoom, feel free to put your questions into the Q&A tab on your Zoom screen. However, we are going to prioritize live questions from the in-person audience. So we may or may not get to those, but do please feel free to add your questions in the Q&A tab. Really quickly, just because those of you who have claimed continuing education credit in a variety of ways over the years, either with this program or others, this has changed. So we have a new platform, so I'm just going to go through it very, very quickly here. There are multiple ways to claim credit. You can do it online. You can do it via text. Those of you on Zoom have seen some of these slides circulating already. There are also handouts and both posted in the back for those of you here in the auditorium with us that you can find and follow the directions to claim your credit for your participation today. This, as you'll see here, there is a code that you want to know. That's the most important thing on this information, 24641. Again, a couple ways to do that, either in the cloud or by text. If you have any questions, if you need assistance with claiming credit, our amazing Medical Center Hour Administrator, Charlene Kaufman, will be happy to help you out with that. So that's, I will step away now that we've gone through those key details. And it's my pleasure to have Angie Hazeman-Bayless come and introduce our distinguished speaker today.
Good afternoon, everyone. As Dr. Mutter shared, I'm Angie, and I am the Director of Clinical Nutrition here. I'd like to first thank Dr. Mutter, Dr. Downs, Office of Diversity, Equity, and Inclusion for all they did to make today's presentation happen. I also want to share my deep appreciation for our SLP and RD colleagues who really advocate for a speaker on this topic. And with that, I'm thrilled to have the honor of introducing our guest today. Ragen Chastain is a speaker, writer, researcher, board-certified patient advocate, and multi-certified health and fitness professional. She's an internationally recognized expert and thought leader in weight science, weight stigma, health, and healthcare, who has presented at large-scale companies to students, faculty, and staff at top universities and healthcare organizations, and at healthcare, fitness, and corporate conferences internationally. She has developed an abundance of resources on these topics, which were listed on our intro slides and will be referenced in her final slides. She describes herself as an unwavering advocate for size acceptance, noting that basic human respect is for people of all sizes, which will be highlighted in her presentation on healthcare for everybody, caring for higher weight patients. In her free time, she just happens to be a national dance champion, a triathlete, a marathoner who holds a Guinness World Record for heaviest woman to complete a marathon. She lives in Oregon with her fiance, Julianne, and their adorable foster dogs. Please join me in giving Ragen a warm welcome.
Thank you so much. Thanks for all of the effort. I know these things are no small thing to put together, so I hugely appreciate being able to be here. Thanks to you for being here. I'm excited to talk about this. We're going to talk about healthcare for everybody, best practices for caring for higher weight patients. My name is Ragen Chastain. Pronouns are she, her. That is my email, Ragen@weightandhealthcare.com. So if you do have questions about this that come to you 2 weeks or 2 years from now, please feel free to reach out. I pretty much live to talk about this stuff. I have no conflicts of interest. From an introductory perspective, this is going to be a broad overview, and I'm going to err on the side of sharing a lot of information. So please don't feel like you have to process all of this today. I just know that people are coming with different levels of knowledge, and I want to make sure there's something for everyone. I'm not a doctor. I don't play one on TV. I'm a researcher. My area of expertise is the intersection of weight science, weight stigma, and healthcare research, with a subspecialty, as it were, in the ways that the weight loss industry has worked inside and changed the healthcare industry. We come from varied experiences, and I just want to acknowledge that various identities, various experiences mean that we don't have the same experiences within the healthcare system. And some of what I say today may be different than what you learned, than what you've taught others, than what you're sure of. And in the almost 22 years that I've been working with this research, I have had all the reactions: disbelief, denial, anger, incredulousness, defensiveness. And so if that's coming up for you, I just want to first name that as valid, and also say that I offer that as an invitation to explore and to dig deeper. And if I can help with that, please do not hesitate to reach out to me. Quick word about language. The terms obese and overweight. These are terms that were literally made up for the express purpose of pathologizing bodies based on shared size, rather than shared symptomatology or cardiometabolic profile like we would see in a typical disease diagnosis. I urge you to read books like Sabrina String's Fearing the Black Body and Deshaun Harrison's Belly of the Beast to understand the origins of the concept of pathologizing higher weight bodies. The impact of this idea has been tremendous profit to the weight loss industry, who have been and continue to be sort of the primary architects of the paradigm. A lot of treatment differences for people within these higher weight classifications, and a lot of fractured relationships between higher weight patients and healthcare providers and healthcare in general. You may have heard the idea of person-first language, that it's less stigmatizing to say a person with obesity or a person with overweight. The first thing I want you to know is that this is not coming from weight neutral health community, from health at every size community, from fat activism community. This is coming directly from the weight loss industry as part of the goal of having simply existing in a higher weight body, regardless of actual health status, be seen as a chronic lifelong health condition requiring chronic lifelong treatment. And so the problem with this, besides becoming sort of unwitting marketers for the weight loss industry, is that the idea of people first or person first language is being co-opted from disability community, where there's a lot of conversation and transformation happening. And again, I urge you to read and listen to folks from that community to understand those nuances. But absent those nuances, this idea was sort of taken by the weight loss industry and plopped onto higher weight people. And the problem is that while it's being marketed as anti-stigma language, it's actually more stigmatizing, because we don't talk about bodies like this, right? I'm not like, gosh, I hope my friend with tallness comes over soon because I have to change that light bulb. Or, oh, this seat's actually taken, my friend with blondness is going to be here soon. Or, oh, that man affected by thinness getting on the bus. I believe I know him. This isn't how we talk about bodies. So when we suggest that simply existing in a higher weight body is so terrible that we can't accurately describe that body, we need a semantic workaround that actually generates stigma. And so the terms obese and overweight, person first language, these terms are considered stigmatizing and are roundly rejected by weight inclusive health community, health at every size community, fat activism community. If we want truly non-stigmatizing language, we need language that accurately describes these bodies without pathologizing them, and that isn't terms that were used as slurs or taunts that could hurt people. And so examples of that are higher weight, people of size, larger body, higher end of the weight spectrum. So we've got those terms, and then we've got fat. Fat is my preferred personal descriptor. Fat is also a reclaiming term with all of the complexities that come with reclaiming terms. So there are people who could be described as fat who absolutely don't align with that term, and that is completely valid. I like it because it's a reclaiming term. It kind of tells my bullies they can't have my lunch money anymore, right? You can't offend me by accurately describing my body. What's important though, I'm not asking you to start charting patients as fat or to use the descriptor if you're not comfortable with it. But if somebody does use this descriptor about themselves in a positive or neutral way, it's critical that we are not correcting them. We don't want to say you're not fat, don't use that word, don't call yourself fat, because when we do that, we suggest that there's something wrong with being fat. People are fat whether we call ourselves that or not. And so we want to let people choose how to describe themselves, and we want to support them in that. So throughout this talk, I'll use quote obese and quote overweight when I'm talking about studies that use those terms. I won't use person first language, and I'll use higher weight, people of size, larger bodied, and fat interchangeably. Let's talk a bit about weight stigma in healthcare practice. There are 4 main types. The first is implicit bias. This is subconscious bias. We live in a world with a tremendous amount of weight bias. So if we have subconsciously internalized some of that, that wouldn't be like a galloping shock. However, we can do a lot of harm still from an implicit bias place. One example would be if a healthcare provider, every time they see a higher weight patient, they just tell them to start an exercise program without even thinking about it, just assuming that they wouldn't have already been participating in one, right? That's an example of implicit bias. And so we're responsible for the harm that we do, but it is a subconscious situation. Then there's explicit bias. These are folks who are aware that they have negative beliefs and preconceived notions and stereotypes about higher weight people, and they're acting on them intentionally. And in this case, the harm is intentional, though it's sometimes couched, and people sometimes believe that they're doing the best they can for someone as for their own good or tough love. But I urge us to rethink this kind of treatment of patients and people in general. Then there's internalized bias. This happens when higher weight people internalize negative beliefs about our own bodies. This can cause us to participate in our own poor treatment. It can also cause us to participate in the poor treatment of other higher weight people. And finally, there's structural bias. And this happens when the things that higher weight people need don't exist for them or don't exist for them in the space they need them to. This can be everything from a sturdy armless chair in a waiting room, a properly sized blood pressure cuff or gown, an MRI, research that includes higher weight people. All of these things are structural bias. And all types of stigma and bias require systemic solutions, but structural bias can only be solved systemically. You can have a fully fat affirming patient, a fully fat affirming provider, but if the MRI is not big enough, that patient's not getting care. And this type of bias gets exacerbated when we blame the patient, if we say the patient's too big for the MRI, when in fact the MRI is too small for the patient. Healthcare needs to accommodate the people who exist. People should not have to change themselves to fit into healthcare. So the impacts of this on the patient side tend to be a lot of disengagement. Canceled appointments, delayed appointments, disengagement from care, lack of early detections and screenings, internalized weight bias, mistrust of other provider recommendations. On the provider side is what I call practitioner weight distraction, which is when we see higher weight patients as sort of walking, talking pathologies. It can cause a situation where diagnoses are missed, where recommendations are missed, where a weight loss prescription can be given where a thin person with the same symptomatology or presentation would be given a different treatment. And then the patient goes off and tries to lose weight, their health condition progresses, right? And then they come back with a worse situation, and that then gets blamed on their weight, so it can cause a vicious cycle. And then practicing stereotypes instead of medicine. And I'll give you a quick personal example. I was establishing care with a new provider, and toward the end of the appointment, he said very seriously, "I need you to do something for me. And it's gonna be so hard. But if you can do it, it's gonna change your life." And I was like, I'll bite, what is it? And he said, "I need you to start walking 10 minutes a day." And at the time I was training for my first marathon, and I had done 18 miles the night before. Which I told him, and he said, "Look, if you don't want to do it, that's fine, but you don't have to lie about it." Yeah. That would be explicit bias, if anyone's curious, right? But this can become a real issue in terms of patient care, patient engagement, patient trust. So the weight-centric paradigm that we're in now is a paradigm where we see simply existing in a higher weight body as a health issue and weight loss as a cure. And I want to look at the research in this, and I want to start with behavior-based weight loss interventions. And I want to be clear that these interventions are any attempt to purposefully decrease body size based on the idea that a thinner body will be better or healthier than a fatter body. And this can include food and or movement or other behaviors. It might be called dieting, a lifestyle change, a health plan, a nutrition plan, medically supervised weight management. If we're trying to use behaviors to manipulate a patient's body to be smaller, that's what we're talking about here. And I'm being very explicit about that because often the research I'm about to talk about, people misunderstand to believe only to be about commercial dieting or fad dieting, when in fact it's about all of the intentional behavior-based weight loss interventions. So this is how I got into this. A little over 20 years ago, I had been yo-yo dieting for years, and I decided to find the best diet, the diet with the highest efficacy. And because my background is research methods and statistics, I decided to do that with a literature review of the weight loss research. I cannot stress enough, I was not in school I did not get credit. I did not publish. I had a corporate job. This is the kind of nerd I am. This is how I like solve my life problems. And when I got to the end of my literature review, I was so surprised and shocked and dismayed and in disbelief and angry and defensive about what I found that I did the whole thing a second time. And what I found is encompassed in this quote: there isn't even one peer-reviewed controlled clinical study of any intentional weight loss diet that proves that people can be successful at long-term significant weight loss. No commercial program, clinical program, or research model has been able to demonstrate significant long-term weight loss for more than a small fraction of the participants. Given the potential dangers of weight cycling and repeated failure, it is unscientific and unethical to support the continued use of dieting as an intervention for, quote, obesity. And that is exactly what I found. And I found it's not new information. In 1959, Stunkard found a greater than 95% failure rate for their 100-person study. They also looked back at the previous 30 years of research and found the same thing. So we're now talking about research from the 20s. In 1992, the National Institutes of Health issued a statement that almost everyone who loses weight regains it. Replicated in 1999 by Miller, 2007 by Mann and Tomiyama. In 2013, the Australian National Medical Health and Research Council put this out as A-level evidence. In 2020, a Canadian panel of, quote, obesity experts came to the same conclusion, and Gazer and Ngati in 2021. This is now 100 years of research showing that almost everyone loses weight short-term in about the first year. About 95% regain the weight between years 2 and 5, and up to 66% of people regain more weight. That's considered a healthcare intervention that's prescribed to 70% of the population that has the opposite of the intended effect the majority of the time. And that is what we're talking about here. And what we find is that intentional weight loss attempts change the body physiologically. The body reacts with physiological changes that create essentially a weight maintaining, weight regaining machine that far outlasts the weight loss attempt. So who here has heard the idea that 5 to 10% weight loss creates clinically meaningful health benefits? Yeah, me too. So this has been a claim for a long time. So let's dig into this. First of all, how are we defining significant? This has been a great falling number, like off a cliff. So it started with the Metropolitan Life height weight tables, and they were very specific. If you're this height and this frame, this is the healthy weight for you. They couldn't get people to lose anywhere near that amount of weight. So they switched to 20% on the idea there was a good amount of weight loss, and it was, and I'm quoting, memorable. But they couldn't get people to lose anywhere near that amount of weight. So they went to 5 to 10%. And recent guidelines have gone to 3 to 5%. This is an amount of weight loss I could lose right now with a loofah and a haircut, right? And we're considering it clinically meaningful. Again, not from clinical research, but from the weight loss industry setting the standard at what they managed to achieve. So just looking at this over the years, in 1942, I would have been told I had to lose at least 150 pounds for clinically meaningful health benefits. In 1959, 57.6 pounds. 1995 to the recent present, 14.4 pounds. And these most recent guidelines, 8.6 pounds. That's like a beard trim, y'all. And this is considered clinically meaningful. So Tomiyama, Ahlstrom, and Mann decided to dig into this. Do these small amounts of weight loss really create health benefits? And what they found was, quote, in correlational analysis, we uncovered no clear relationship between weight loss and health outcomes related to hypertension, diabetes, or cholesterol, calling into question whether weight change per se had any causal role in the few effects of the diets. Increased exercise, healthier eating, engagement with the healthcare system, and social support may have played a role instead. And so what they posited was that in these interventions, people make behavior changes. And then they experience health changes and a little bit of typically temporary weight loss. And even though the weight loss is small and simultaneous, we credit it with the health changes, ignoring the behavior changes that preceded it. And so they posited perhaps it's the behavior changes that are actually creating these health changes and not these small changes in weight. And we'll look at this more in a little bit, but there are other ways that research misleads us. And it's important to understand how much of this research is funded by and conducted by the weight loss industry. And so part of what we find is short-term focus. Very rarely is this research more than a year. And when it's 2 years, we see weight go down and come back up. And then they stop and say, right, but people didn't regain all the weight. Right? But fun research fact, if a variable is going straight up, you're not supposed to stop observing it and assume it leveled off that day. Like you will for sure fail freshman research methods class if you pull that. but it happens constantly in this research. Ignoring dropout rates, not just not following up, but writing a conclusion as if those people never existed. Poor design and inappropriate conclusions, and Weight Watchers give us an excellent example. So they tested 3 things: a brief intervention where people were given a pamphlet and some advice. That's the blue line we see at the top. A 12-week Weight Watchers program, which we see in the green line, and then the red line at the bottom is a 52-week program. And so what we see is people lost weight and then they all started gaining it back. And in fact, the people on the 1-year program are regaining faster than the other 2 groups. The study's conclusion: although it costs more, modeling suggests that the 52-week program is cost-effective in the longer term. For what? This study, you may not be surprised to know, was funded by Weight Watchers, but they successfully used it to get Weight Watchers into companies and healthcare system as an effective intervention. So in the research, there's 2 basic premise errors that sort of prop up this whole thing. The first is, all right, if higher weight patients experience a health issue more often than thinner patients, then their body size is to blame. This is your standard correlation causation error, right? 2 things happen at the same time doesn't mean one causes the other. Now, this is complicated because in medical research, we use correlation all the time, but it's not responsible to do that without investigating possible confounding variables, right? What else happens to this population that might lead to these outcomes? And testing rate is one example of that. Research shows that higher weight people are very often having their blood pressure taken with a too small cuff. This will give an artificially elevated reading. And then we hear how many higher weight people have high blood pressure. To what extent is that because of miscuffing? Right? We don't have that answer, but it's something that we have to look into. There are also confounding variables, and we're going to dig into these, but weight stigma, weight cycling, and healthcare inequalities are correlated with the same issues that get blamed on weight. Right? But the research that tries to correlate weight and health doesn't mention these typically, let alone control for them. And so this is incredibly important that we can have correlational research, but we have to be responsible about it. And currently we're not being responsible about it. And I think about the fact that cis male pattern baldness is incredibly highly correlated with cardiac incidents. And if we just stop there, we'd say, we got to get these people to grow hair. It's the obvious difference, right? But obviously we didn't stop there, and we learned that it's a 3rd factor that causes both the baldness and the cardiac incidents. But when it comes to weight, because of this sort of everybody knows idea, because of the tremendous amount of weight stigma and assumption, as soon as weight is correlated with a health issue, we become very comfortable saying it's obviously caused by weight. Interesting case study about that. In 2009, there was an H1N1 outbreak, and higher weight people had worse severe outcomes and death. And I was in the field at the time, and the research that was coming out was like, what's wrong with fat bodies, right? Is it low-grade inflammation caused by, quote, obesity? Is it acting in the adipose tissue? Like, what's the deal? And so Sun et al. Did a retrospective on this, and they found that, in fact, thin people were simply given earlier antiviral treatment than fat people were. And that, quote, after adjustment for early antiviral treatment, relationship between, quote, obesity and poor outcomes disappear. Right, so this is an example of a treatment difference creating an outcome difference, but then being blamed on weight. So the second basic premise error is, okay, well, if higher weight patients experience a health condition more often, or if an intervention is less effective for them, then the solution is to make them thinner, right? Weight loss is the cure for this. And the first problem is that you can have people of the exact same weight with vastly different health statuses. You can have people of vastly different weights with the same health status. So when we start to make weight a proxy for health, we run into problems right away. We can also see people have weight changes without any health changes, and people experience health changes without weight changes. So when we make weight loss into a proxy for health or health supporting behavior or health supporting intervention, we run into problems. We also know the success rate of intentional weight loss is pretty abysmal, and that patients need help now, not at some sort of indeterminate hypothetical time when they will look different. All right, so let's look at these confounding variables in more detail, and let's start with weight stigma. Munich et al. Found that cis women who say they feel they are too heavy suffer more mental and physical illness than women who say they feel fine about their size no matter what they weigh. Another Munich study found that experiencing weight stigma over time was associated with increased rates of high blood pressure and diabetes. Hull et al. Found increased blood pressure, blood sugar, levels of cortisol, depression, anxiety, substance abuse, and suicidal tendency, more advanced and poorly controlled chronic disease, and low health-related quality of life. Sudin et al. Found perceived weight discrimination was associated with an increase in mortality risk of nearly 60%. So when we hear about weight-related health issues or quote obesity-related health issues, what we might also, or in fact be talking about are weight stigma-related health issues. Then there's weight cycling. Gazer and Gotti found the risks associated with weight cycling are very much the same as those associated with quote obesity. And as we saw, weight cycling is by far the most common outcome of weight loss attempts. Bacon and Aframore found that attempts to lose weight typically result in weight cycling, as we saw. Weight cycling results in increased inflammation, which in turn is known to increase the risk for many, quote, obesity-associated diseases. Weight cycling is associated independently with type 2 diabetes, hypertension, cardiovascular disease, and increased mortality risk. In fact, they found that weight cycling could account for all of the excess mortality that was attributed to, quote, obesity in both Framingham and the National Health and Nutrition Examination Survey. So here again, when we talk about weight-related health issues or, quote, obesity-related health issues, we might be talking about weight cycling-related health issues. And then the third is lack of access to ethical, evidence-based equal health care. And this starts with research. I just gave a talk to a conference of anesthesiologists, and in reviewing the guidelines for the past 40 years, they all said something like, we know pharmacokinetics and pharmacodynamics are different in people who have more adipose tissue, but we don't know how because they were excluded from the studies. Anyway, here's some guidelines. Not like, dear God, we don't know what we're doing and we need some research right now, but like, meh, what are you gonna do? Right? This is incredibly problematic. The healthcare system in general was created using research that excluded higher weight people. And then when that healthcare system produces worse outcomes for higher weight people, it gets blamed on their weight. Accommodation, like we talked about, chairs, tools, durable medical equipment, training, practitioner bias. And often higher weight people's healthcare is informed by two underlying, sometimes subconscious tenets. The first, that it's worth risking fat people's lives and quality of life in attempts to make us thin. And the second is it's acceptable to insist that fat people become thin before they can access the same care a thin person could. Right? And so that system does not treat higher weight people equally. Harriot et al. Is an interesting case study of all of this. So they looked at commercial weight loss programs, and their conclusion was all diets in the diet trials were ultimately successful in achieving weight loss in those who complied. This is a 16-week study, first of all, so like not that long. But what they left out is that 64% of subjects had withdrawn by week 8. Another fun research fact, if 2/3 of your sample nopes out, you are responsible for caring about that. You are not supposed to erase them to make your intervention look like it has higher efficacy. But this is incredibly common in the research. Wharton Cook et al. So this was a study that looked at effectiveness of a community-based weight management program, and the headline ran, psychiatric drugs aren't barriers to success in weight loss program. Their stated conclusion was, and this is the only thing you can get without going into the paywall, results of this study suggest that those who participate in a weight management program can lose significant amounts of weight regardless of psychiatric medication use. Think in your mind, what would you think significant amounts of weight might be? And then ask yourself what I think it was, 2.9% of body weight, because that's what they lost. And their justification was that, yes, this is modest, but it's consistent with 3% achieved on average from long-term lifestyle interventions. So basically they said nobody loses weight, so everybody does. But you can't get this information without going beyond the payroll and then digging into the discussion section of the article, Ask Me How I Know. Right? So this is incredibly problematic that this is the research that's out there, because as providers, you're supposed to be able to read this conclusion and believe it. Right? But this is incredibly misleading. So let's talk about weight loss surgeries and weight loss drugs. So when we talk about weight loss surgeries, at the base, they're taking a healthy, correctly functioning organ and digestive system, and they're surgically putting them into what would otherwise be considered a permanent disease state, and they're often forcing behaviors that mimic eating disorders. Now, I take a firm view of bodily autonomy. There are, people are allowed to do what they want with their body, but I think we should be clear about what's happening. There are 3 main outcome groups. There are the people who are happy. Sometimes they're in that 1 to 3 year honeymoon period, but often they had the surgery a long time ago. Sometimes they've had what I would consider to be significant side effects, but they're happy with the outcome. Group 2 are miserable. These are people who've had significant lifelong side effects. They will say they would do anything to take the surgery back, that it was a terrible decision. And group 3 are no longer alive. They may have passed away on the table. They may have passed away later. Right? The issue with the research around these surgeries is that we don't have good prognostics for who's going to be in what group. And there's not very much long-term data, very, very little past 10 years. And what there is typically only captures adverse events for the first 30 days post-surgery, which is a real disservice, and considers people, if they're below their baseline weight and they are still alive, they are considered successes. So everyone in group 2 is considered a success in the data. Further, these surgeries can sometimes be marketed, right, in ways that use brochures and videos and seminars that only ever include people from group 1. And this is a huge problem. Given the issues with the research, it's very difficult to capture informed consent for these surgeries. But if we are only ever promoting people from group 1 as if those are the likely and only outcomes, we're not giving people a chance for informed consent. And that's where my concern comes in. And again, the underlying tenets can be that higher weight people should be willing or sometimes convinced to risk their lives and quality of life in an attempt to become thinner, often to cure or prevent health problems that thin people get, but from whom these same risks aren't asked. In terms of weight loss drugs, the history has been being approved on a really skewed risk-benefit analysis. So you've got this mountain of sort of poorly created correlational studies that link being higher weight to health issues without any kind of investigation of confounding variables. And then they say, see, it's so terrible to be higher weight that it's worth the risk. This is what happened with Belviq. They were denied in 2009 because of their side effects. But they came back in 2012. They didn't change the drug. They just said, no, it's so terrible to be fat that it's worth the risk. And the FDA agreed and approved the drug. And then, of course, the drug had to be taken off the market because of the exact same side effects that they had known about in 2009. So then these drugs get marketed and prescribed based on short-term research and a small amount of weight loss. They end up creating long-term harm and or little weight loss. Often this was predictable from the initial studies, and then there are recalls and market withdrawals, like we see with fen-phen and like we see with Belviq. And so I've done a tremendous amount of deep diving into the GLP-1, GIP co-agonist drugs. We're not going to go, that's a whole other hour-and-a-half talk. But I just want to kind of give an overall situation. So first of all, these are solid type 2 diabetes drugs, right? They work well for people who are contraindicated for other drugs. They work well for people who couldn't get the glycemic management they wanted on other drugs. And what happened was they had a modest side effect of a little bit of weight loss. And so the company said, well, if we gave people a ton of the drug, would that create more weight loss? And it did, and that's how we got these as weight loss drugs. And so it's a dosing and titration issue. For type 2 diabetes, the goal is to give the least medication possible to achieve glycemic management and minimize side effects. The goal of the weight loss application is only to maximize side effects, which of course is going to maximize all dose-dependent side effects. And we know, because they couldn't wait to tell us, that as soon as you go off the drug, you regain your weight rapidly, which means they've created every other weight loss drug that has ever existed. But what they've done from a marketing perspective is say, oh, no, existing in a higher weight body is a chronic lifelong health issue, so you just take the drug for the rest of your life. However, their research doesn't support that that's necessarily even going to work, right? Because we see at the end of this first graph is their 68-week approval study, and we see weight is slightly ticking up at the end of 68 weeks. Then in the 2-year study, we see weight at 68 weeks starts to weight cycle. It's trending up there at year 2. And what they had said was averaging 15% weight loss. And there's a lot to go in there, but we'll leave that for now. Now they've put out their 4-year outcomes, and they're down to 10% weight loss. But what they didn't feature in the headlines is that they started with about 9,000 people and ended with about 900 in 4 years. That did not make the headlines, right? But it's important to know. So we have no idea if this is even possible to stay on this drug and maintain benefits. The side effects are significant. Boxed warning, of course, we know a lot of gastrointestinal side effects that are common, a lot of severe side effects. There have been certainly deaths from this, including from ileus, which they had to later go back and add as a severe side effect. So per 100 patient years, and this is for Wegovy, they've got 532.3 adverse events, 6 serious adverse events, and 4 serious events that lead to discontinuation. So if a patient is 47.3, which was the average age of a patient in their approval study, and let's say they just have a lifespan of 70 years, even if we sort of lowball it, they're looking at 121 adverse events, 1.32 serious adverse events, and 0.9 events that lead to product discontinuation. If a patient is 12 years old, which is the youngest age that this is currently approved for, we're talking about 58 patient years, again, using just a 70-year lifespan, 308 total adverse events, 3.48 serious adverse events, and 2.32 events that lead to product discontinuation. So even if people can get the drug, and even if they can afford the drug, it does not look like people are going to be able to stay on this drug for their whole life, even if it did lead to significant long-term weight loss, which their research doesn't support. So I am not as excited about these drugs as a lot of people are. We're seeing a lot now of, oh, well, it's not just weight loss, there are other impacts, right? And one thing to know is that those other health impacts are happening before much weight loss happens, right? In all of the studies. But I want to look at their cardiovascular trials. So they released a headline, a press release, not the study, just a press release that said, semaglutide 2.4 reduces the risk of major adverse cardiovascular events by 20% in adults with quote overweight or quote obesity in the SELECT trial. So it's important to know 20% is the relative risk reduction. This looks at the occurrence in the two treatment groups relative to each other. It does not tell you how it will impact the regular general population. For that, you need absolute risk reduction, which we'll get to. They only included 3 of the major adverse cardiac events. They said in adults, but they're defining adults as people over 45 with existing cardiovascular disease and without type 2 diabetes. Not the definition of adults I've typically seen. And I think body mass index is a super problematic, predominantly useless measurement, but at least it's clear, right? A BMI of quote overweight or obesity would be 25 plus, but in their study, they used 27 plus. So every single statement in this headline was misleading, but it wasn't easy to fact check it because the study wasn't out. Again, fun research fact, making up your own criteria for terms that have established meaning, not a best practice, you will again fail freshman research methods. But Novo Nordisk stock went up 17% in one day. When the actual trial came out, it's a 1.5% reduction. And it's in a combination of the 3 events, not in individual events. It was only statistically significant for white men with an average age of 61.6. It was not statistically significant for women, Black people, Hispanic people, those at the highest end of the weight spectrum. And in this study, as with every study I'll talk about today, there was no trans or non-binary representation. So what we're hearing and what the research says, there is a chasm there. So I urge you to really dig when you hear that it works for this and that, because there's a loophole in Medicare Part D where they won't cover weight loss drugs, but they'll cover them if they have other uses. And so I really feel like they're just trying to like p-hack their way to approval. Right? But I really say question this and read the research and ask questions about it. So what we've got in general is a cycle of harm to higher weight people in healthcare where we create and perpetuate weight stigma and weight cycling and care inequalities. Then we blame higher weight people's bodies for the negative outcomes that result. Then we use those negative outcomes to justify additional weight stigma and weight cycling and care inequalities. And it is a vicious cycle that harms higher weight people at every aspect. And the only way to fix it is to break it. So the question to ask, the natural question, what would higher weight people's health outcomes and lifespans be if they were not constantly subjected to weight stigma and weight cycling and healthcare inequalities? And that was the Debbie Downer portion of our show. We will get to some more pleasant stuff now. We're going to look at weight neutral interventions, which is supporting health directly rather than trying to manipulate body size as a path to health. So this is Weigh It All. They looked at 25,714 adult cis men. And they were looking at the relationship between participating in fitness and relative risk of all-cause mortality. These gray bars are quote normal weight, quote overweight, and quote obese men who were not participating in fitness. And we can see that as BMI gets higher, the relative risk of all-cause mortality is also higher. Now, we can't say that this is caused by body size, again, because of the number of confounding variables that exist. But we do see that it's there. These red bars are those same categories of men who were participating in 170 minutes of movement a week. And what we see is they had essentially the same relative risk of all-cause mortality regardless of size. Matheson et al. Took this further. They looked at 4 habits, 5 or more servings of fruits and vegetables, exercise more than 12 times a month, alcohol up to 1 drink a day for cis women and 2 drinks a day for cis men, and not smoking. So here we have health hazard ratio on the y-axis, number of those 4 healthy habits people were participating in on the x-axis. And then on top of each of those numbers, normal weight, quote overweight, and quote obese. And again, for those participating in none of the habits, we see that health hazard ratio is higher with higher BMIs. Again, we can't say that is caused by body size, but we do see that it's there. For those participating in one habit, significantly compressed. For those participating in all four, again, essentially the same health hazard ratio regardless of size. And obviously, a lot more than behavior goes into our health. And if you put socioeconomic status over this graph, it changes, but the structure does not. Over and over, we see when we actually take behaviors into account, they are a better predictor of current and future health than is weight or weight loss. Gazer and Agati, a huge study that looked at fitness and health. They looked at 225 studies, systematic reviews, and meta-analyses. They found that the mortality risk associated with, quote, obesity is largely attenuated or eliminated by moderate to high levels of cardiorespiratory fitness or physical activity. They found that most cardiometabolic risk factors that are associated with, quote, obesity can be improved with exercise training independent of weight loss and by a magnitude similar to that observed with weight loss programs. They found that weight loss, even if it was controlled for intentionality, was not consistently associated with lower mortality risk. They found increases in cardiorespiratory fitness and physical activity were consistently associated with greater reductions in mortality risk than intentional weight loss. And they found that weight cycling is associated with numerous adverse health outcomes, including increased mortality. So what they suggested was that people might be more likely to engage in fitness if they were told that there were tremendous benefits that could come from it without weight loss. Right? Because what fat people get told is, oh, you should exercise because it'll make you lose weight, which will make you healthier. So they start a fitness program, they lose a little weight, they plateau, they gain it back, they quit. Hard enough to get time to go to the gym, let alone if you think it's not working for you. And so again, nobody's obligated to participate in fitness. But if we give people true information, we let them make a good informed decision about how they want to support their health and reach their goals. Now, those are all observational studies. It's hard to find randomized controlled trials because most of the money is earmarked for quote unquote obesity prevention and treatment. But Bacon et al. Did a randomized controlled trial, 6-month RCT, 2-year follow-up. At 6 months, 41% of the diet group had dropped out, only 8% of the weight neutral group had. Follow-up, about 50% of both groups returned for the 2-year evaluation. The weight neutral group maintained weight, improved all outcome variables, and sustained their improvements. The diet group, weight was regained and little improvement was sustained, which is what the research we've seen would suggest. So what we're talking about here is a change in focus. Then instead of myopically focusing on manipulating the weight of fat patients, we start focusing on supporting their health at their current size in research, tools and equipment, practitioner training, right? Not just compassion, not just we shouldn't treat fat people badly, but like what does the research say are the best practices here and how can we advocate for what we don't know? So if your patient does want weight loss, and I get this question a lot, first of all, understand they didn't get that idea from nowhere, right? They've probably been told by every healthcare provider they've ever seen it's a good idea. So I suggest asking why. What are you hoping weight loss will do for you? And if we listen, it's usually one or more of 3 buckets. Either they're trying to cure or prevent health issues, they're trying to increase mobility or ability, or they're trying to escape weight stigma. And so for the first 2 buckets, we can explain that, look, people of all sizes have these health issues. They're not solely fat people issues. And so being thin can neither be a sure preventative or a sure cure. And we have ethical evidence-based interventions to help with all of these things, right? Escaping weight stigma is more difficult because weight stigma is real and it impacts our lives in every aspect. And so for me, I realized I had spent years fighting my body on behalf of weight stigma. And what I would rather do is fight weight stigma on behalf of my body. And it has been the most important decision that I've made in my life and has allowed all the other things in my life to happen, right? But a lot of patients don't even know they have that option. So this may be a referral to talk to someone. It may be a referral to resources around size acceptance, fat activism, weight neutral health community, but letting people know they have options is incredibly important. And again, always going back to informed consent. So practical steps, focus on health, not weight. Don't blame fat patients for healthcare's shortcomings, right? The system's failing the patient, not the other way around. Do your own work to identify and dismantle weight stigma and bias. Encourage patients to see their bodies as amazing and capable and worthy of care, and offering blame-free, shame-free, future-oriented care. Weigh in only when medically necessary, and this can be tricky because sometimes EHRs ask for weight, or with MIPS, it can be part of incentive pay. But with MIPS, if the patient declines weigh-in, they're removed from both the numerator and the denominator of the calculation. And even if they're not, none of that negates the patient's right to informed refusal of this as an intervention, right? So allowing patients to opt out, considering signage, never offered to guess a patient's weight. The first time this happened to me, I was so shocked. I literally said, yeah, no, this is not the county fair. Like, we're not guessing my weight today. And now what I say is, look, either a number is medically relevant or it's guessable. And since you've told me it's guessable, we know it's not medically relevant. So just put patient decline. Right, but I've had to decline blood pressure many times because they didn't have a properly sized cuff. In my life, no one's ever asked me to guess my blood pressure. Right, so let's stop asking patients to guess their weight or guessing their weight. If you're thinking that weight loss is the solution, asking yourself, what would I do for a thin person in this situation? Choosing interventions based on therapeutic effect first, not weight impact. And again, talking to the patient about all the options. Doing whatever you can to make your facility accommodating. Notice what's different for higher weight patients and fix it. Be on a team with your patient against weight stigma. Have policies already in place for all eventualities that might happen with higher weight people and talk to patients about it. Don't talk about them in front of them. If you or your facility cannot accommodate a patient, apologize and proactively learn where to refer. Right? If you don't have the large bore MRI that they need, figure out who does so the patient doesn't just disengage from care. Speak up against weight stigma and fat shaming and diet talk. Finally, even if I'm wrong about everything, and I have to say that, right? Or I would be no kind of scientist. Even if I'm wrong about everything, even if higher weight people could all become thin, even if by becoming thinner, they would all become healthier, higher weight people would still deserve equal accommodation and access to the world, including healthcare. Higher weight people have the right to exist without shame, stigma, or bullying. It doesn't matter why they're higher weight. It doesn't matter if there are health impacts of being higher weight. It doesn't matter if they could or even want to become thin. Higher weight people deserve equal access to the world, including healthcare, period. All right, you made it. We are at the Q&A, which is my favorite part. If you have questions, you're welcome to message or email me. You can also find more resources at the Health at Every Size Health Sheets or Weight in Healthcare, all free resources.
Thank you so much. And again, we've got a microphone on this side of the auditorium. Angie's got one on the other side. So raise your hand. We'll bring you a microphone.
Hi, thank
Hi.
you so much for your excellent talk.
Thanks.
I wanted to ask, so I know that a lot of scientists and healthcare professionals kind of rely on hearing, oh, well, this study found this, it was a peer-reviewed controlled trial or whatever. Like a lot of people focus on the peer-reviewed. So I wanted to ask, as somebody who is like deep in the kind of research area, what do you think the role of peer review in these studies is, that you're looking into peer-reviewed studies and you're finding their conclusions are not supported by the data?
Yeah, so I don't think everybody is just like making bad research for profit. I think there are people making bad research for profit. I think the peer review system is unbelievably broken. You're asking people to volunteer for a difficult task, right? And there's a recent Novo Nordisk study that when I looked into they thanked their peer reviewers, which is weird. So when I looked in, one of them had benefited, it looked like, from a scholarship of Novo Nordisk. One of them had stock in Novo Nordisk. And I contacted the journal and was like, what happened? And they were like, well, it's an honor system. So I think that we have a really broken peer-reviewed system. I also think there's a lot of shenanigans that you have to really read to see. And since a lot of people are coming from this paradigm that they've never questioned, right? Higher weight is a health issue, weight loss is a solution. They're just not questioning. Like the tirzepatide study, their long-term study, which is Zepbound, they said that 80% of people-ish maintained a 20% weight loss. But they defined, so they defined maintained as didn't gain back more than 20% of the weight within a year. And like, if I was in a race and I said I started in first place and I maintained that, I think you'd be surprised to learn I finished in 19th place, right? So they're really manipulating language and you have to dig. And I don't know that peer reviewers have the time or the expertise or even are in the cognitive space to do it, right? Because this is just what we've learned and we all believe it and everybody knows, and it's, you just move on without really digging. So I think that's a huge problem.
So then do you have any kind of recommendations for, because I find myself in that problem where, somebody says, well, this article found this, and I'm like, okay, now I have to go to the methodology. So like, do you have any recommendations for kind of Like, so that we're not trying to disprove every single paper ourselves?
Yeah, so I think, first of all, look, if it's trying to make a claim about weight and health, asking, did this control for weight signal, weight cycling, and healthcare inequalities? If not, chuck it. Is this study of weight loss 5 years or more? Chuck it. Right? We have 100 years of data that shows people don't maintain weight loss to 5 years. So another 16-week study is helpful to know if we should do more research, but is not actually conclusion. A big part of the problem is that we're using research that should just be considered like pilot studies, but we're using it as if it taught us something. Like 12 mice had decreased insulin resistance. Oh my God, give it to everybody. So I think looking at that is a shortcut, and looking at the figures is an incredible shortcut. Because often a lot of the dirty laundry comes out in the figures, especially if you look at the small numbers underneath.
Thank you.
Yeah, and you can always email me if you're ever like, what do you think about this study? I'm in. Other questions?
Thanks, Dr. Moore. Make you walk all the way up here. Thanks for a great talk, Regan. I really enjoyed it. I was just going to make one statement that really resonated with me. So clinically, I treat bladder cancer. And so one thing we learned from our patient advisory board is we used to give them a medicine called BCG. And so when they didn't respond to it, we called BCG failure. So every time we'd see a patient or we'd discuss them, we'd say, oh, this is a BCG failure. And then what we learned was to call it unresponsive from our patients. So I appreciate how you brought that up in terms of how we label people incorrectly.
Yeah.
Could you talk a little bit maybe about surgery at times? Because I think in the surgical sphere, when folks are going for surgery and based on, say, their BMI, that there are different challenges, and we don't want to deny care, but we also know that maybe the complications rates might be different. And I think that some of the reimbursement does account for that if we code those things correctly. But maybe if you could talk to those things a little bit. Thank you.
Yeah, that's a great question. So it gets really complicated, right? Because higher weight people may have higher complication rates, but is that because it's higher weight, or is that because all the research and tools and best practices that were created for that surgery were created for thin bodies? I'm working on several research pieces about this, and in one of them I work with a surgeon who moved from just doing general surgery to doing emergency surgery. And he's like, yeah, I'm in the emergency room. And I was like, yeah, I need the longer sticks, right? For why can I never remember the word? Help me, surgeon people. Laparoscopic, thank you. And they were like, oh, we don't have those. And he's like, what am I supposed to do? And they're like, well, they might be somewhere else, right? So there are all these pieces. So when we look at the research around surgery, we have to ask ourselves, first of all, does it support the belief of higher complications, right? And I have a series on joint health and joint surgery denials. They mentioned I'm a board certified patient advocate, and a lot of what I do is people who are facing BMI-based denials of surgery. So essentially their healthcare is being held hostage for a weight loss ransom that most of them will not be able to pay. And so in looking at the surgery, there were good studies that said that no, it was worth doing the surgery. The outcomes were similar. Right, so looking at that research, but also getting better at doing surgery on higher weight people, right? We need research specifically about how can we improve outcomes, how can we improve aftercare. And then for now, in talking to surgeons about this, they have said that the things that would most motivate them to not deny care are striation of complications. So if their stats did not take a hit, right? So if you striated complications, say there's a higher expected complication rate, and that will not harm your statistics. And then, as you said, the reimbursement, if pay was commensurate with the extra time that they might need to take. So those things seem to be the most, among the surgeons that I've talked to, those would be the things that would most motivate them to perform those surgeries. But I was doing advocacy for a patient who wanted gender affirming care, and they had been denied their surgery and then referred to weight loss surgery. And we tried everything. And as a last ditch effort, I wrote a letter and I was like, look, and he was denied for anesthesia risks specifically. So I said, okay, can we just can whoever's doing the anesthesia for the weight loss surgery just like come down the hall and do the anesthesia for this surgery? You obviously know how to do it. And it worked and they did it. I don't expect this to work again, right? It seemed like a very like last ditch effort, but it really is one of those areas where, and it's not just surgeons saying, I don't want to work on fat people. It's also like an issue, as you said, of compensation. It's an issue of statistics and the way that their performance is judged and the way that they're promoted. But we have to create a system that is emphasizing giving care, right? Finding ways to make people more interested in giving care to higher weight patients than in declining care for higher weight patients. So I hope that's helpful. It's a complicated question, but yeah. Other questions? We've got a couple more minutes. Yes.
I'm a speech therapist, so I'm not a nurse, I'm not a doctor, but I like to ask questions. And I'm kind of curious. So UVA as a health system has a number of like employee quote unquote wellness programs that partner with groups such as Weight Watchers, which just kind of reinforces a lot of these problematic things. But what are things that a place like UVA as a health system could be doing besides having speakers like you come to get particularly our physicians to understand how to think better on these topics, but also kind of change the culture with the whole institution?
Yeah. Yeah, training is an important part of it. I think just giving people the opportunity to see this information. And I think system-wide, like with wellness programs, I've worked with a lot of people who wanted to challenge their workplace wellness program, and we challenged it on the basis of evidence, right? Can you show me 5 years that people have experienced? And it's not just weight loss, but also health benefits, right? One of the things that happens in the research is that weight loss is assumed to confer health benefits. And so we want to ask both of those are two different things, right? So, you know, looking at where in our culture do we promote something that might not be ethical and evidence-based, but that might have, based on weight stigma, been believed to be ethical and evidence-based? And what can we do that's better than that? Or at least can we provide an alternative? Like, can we create a weight-neutral workplace wellness program where people are focusing on supporting health? And it's not just food and exercise, it's sleep. It's, I hate to say this word to healthcare practitioners, but it's like stress management, right? But it's like, for real stress management, like proper staffing ratios and pay and vacation, not just like muffins in the break room. So it's all of those things, right? Where we're looking at inclusive, holistic, weight neutral wellness rather than just things that target manipulation of body size. I know it.
Thank you so much. That's all the time we have for today. I want to thank our distinguished speaker, Ragen Chastain, for being with us today. If everybody join me in another round of applause. Thanks to our audiences on Zoom, as well as here in Penn Hall. And on your way out, take a look at our flyer for next week. If you're not a Medical Center Hour regular, we have another great event. We're having Dr. Sneha Mantri from Duke University. She'll be speaking to us on Beyond Burnout, Changing the Culture of a Health System, as we just spoke about, with a novel interprofessional program. Thanks.